Thank you very much. Look, it's a great pleasure to present today. I'm glad you've opened up the curtains and let in a little bit of light. It's 2 a.m. in Sydney, so I think it will help me keep you awake. But it really is. I'm very pleased to be here. Thanks so much to Philip for the invitation. Thanks to Bettina as well in terms of helping me out, and particular thanks to Celine, incredibly efficient organisation in terms of my travel and everything, and accommodating a change of travel. I needed to go to Geneva on Friday. Australia has done some things very poorly. Asylum seeker human rights is one thing that comes to mind that we've done incredibly, embarrassingly bad on. Still lots of work to be done in terms of closing the gap as it's known in Australia in terms of Indigenous health outcomes. But hepatitis C is one area that we have done a lot of good things. So I'm sort of here today to tell the story about hepatitis C in Australia. Still have much work to do, but it's been an incredibly exciting last couple of years in Australia, and I'll try and give you some background to why I think we have been one of the countries that has been quite successful. These are my disclosures. As was alluded to, although it's not a conflict of interest, I'd also like to disclose that I had a great autumn weekend in the Swiss Alps and visited a town that hardly anyone knows of, apparently, Blitzingen. Wonderful hotel castle in Blitzingen that I stayed in Sunday night, and a great train trip getting there and then on my way back from Blitzingen to Zurich. So it's been a wonderful last few days. In terms of hepatitis C elimination in Australia, I'll cover an update on DA treatment numbers, look at specific uptake in high-risk populations, some DA treatment outcomes. We have a very large real-world observational cohort study called REACH-C, so I'll show you some data from that. Some screening and linkage to care initiatives that we have in Australia. Some mathematical modelling that we've been doing, looking at the numbers that we need to treat to achieve WHO elimination goals. And some future challenges for hepatitis C elimination. I think one of the key themes is that it's certainly not over. But we have a lot more work to do, even in a country like Australia that's had quite a bit of success over the last couple of years. I just wanted to go over the Australian government program because it really has been pivotal. So some of the key features are that we have unrestricted DA access, have had since March 2016. No cap on the number of patients that can be treated per year, but a cap on expenditure. So there's a risk-sharing arrangement between the Australian government and the pharmaceutical companies, a 5-year contract. And importantly, as I said, there's no cap on expenditure. So each year there's a set amount of money that is put aside in terms of hepatitis C therapeutics, but we can treat as many patients as come forward to receive therapy. The more patients we treat, the cheaper per patient it is. In terms of 2016, we treated a very large number of patients, and I'll show you the numbers shortly, but we estimated that the cost per patient was around about €6,000. So it's been, I think, a really innovative strategy by the Australian government in terms of the pricing of these therapies. And what really sort of led to that arrangement was we had a key stakeholder meeting in 2014. The government got together representatives from clinical, academic, community, and also the pharmaceutical industry, and started to discuss, well, how are we going to deal with very high drug prices, large demand? It was really interesting that some of the clinicians in the room said, well, we need to treat those patients with more advanced disease, they have the biggest need. But the community-based organisation representatives, both the drug user organisations and the hepatitis organisation representatives, said, no way. We're not going to have that situation where we have a prioritised access scheme. We need to have access for all. And I think it was really crucial that their voices were listened to. And one of the key things in Australia is that we have had funding of community-based organisations, both drug user and hepatitis organisations, for many years, and that's been pivotal. I think one of the unique situations in Australia, or relatively unique, is the involvement of non-specialists, and I'll talk about that as we go through. So from day one in March 2016, any registered medical practitioner in Australia could write a prescription for DA therapy. They needed to go through a loop in terms of getting approval from a specialist, so they had to send the patient details to a specialist. So there was a sort of, in a sense, a safety mechanism in terms of that. That was then relinquished several months later once the GPs had developed experience. But I'll talk a bit more about that later on. Minimal administration for clinicians. So when I talk about what the situation is in Australia, most people are surprised by many aspects, but one of the key things is that I can see a patient in my clinic at St Vincent's in Sydney, as long as they've had some blood work done. I can ring up Canberra to get authorisation for that therapy. The call takes about 1 or 2 minutes. You provide limited details. The patient can then walk away with a prescription in their hand and go to a community pharmacy, not just the hospital pharmacy, but a community pharmacy, and be dispensed that therapy that day. Okay, so just in terms of minimal administration for clinicians is really sort of crucial, and a minimal co-payment for patients. So €4 per month for people with a healthcare card, so people on social welfare benefits, and a maximum of €25 per month. So how have we sort of got there? There's some key sort of features in terms of the foundation. The first national hepatitis C strategy in Australia was in 2000. We're in our 4th national hepatitis C strategy. A 5th will be launched very soon. Importantly, it's not part of a HIV, viral hepatitis, STI strategy. It's a national hepatitis C strategy. There was some sort of advocacy to try and get everything combined from the government sort of side, but it's been really important, I think, that we've maintained to have a hepatitis C sort of strategy. I think it's important also that hepatitis B has its own strategy, because there are some really key differences across the two infections. Bipartisan support and political leadership, absolutely essential. In fact, the government that brought in the unrestricted DA program was a Conservative government. It wasn't a left-leaning government. So this was a situation whereby they put $1 billion in the contract over 5 years, was $1 billion Australian dollars to support therapeutics. And a government did that for a population, a largely marginalised population in terms of the community affected by hepatitis C, who weren't traditional voters for that Conservative government. But I think that's come from a background of bipartisan support for HIV response from the 1980s, and there has been, in terms of pragmatic public health, some real bipartisan work that's been done. And this sort of partnership approach that I sort of talked about in terms of the stakeholder meeting has been really crucial. I also mentioned the funding of hepatitis C and drug user community organisations. And we didn't just start getting general practitioners involved in March 2016. In fact, we've had education programs going back to the early 2000s. I also led some pilot treatment programs for general practitioners with interferon-based therapies back in sort of the mid-2000s. So it's something that we've been advocating for many years. In fact, I've been sort of pushing this agenda for well over a decade to get hepatitis C more into primary care, meeting a lot of opposition. So there was obviously many specialists that did not want this to happen, and for obvious reasons. But we kept pushing and said that this had to happen in terms of broadening the response. So I've talked about the national strategy. The other thing that was developed was Australian consensus guidelines on management of hepatitis C, which were launched the day that the unrestricted DA program was launched in the 1st of March 2016. ICI Partnership is a Eliminate C partnership that's been led by the Burnett in collaboration with our institute. It's now a national partnership and really brings together a range of stakeholders to really concentrate on strategies going forward for elimination of hepatitis C. I think everyone's sort of aware of these figures in terms of the WHO elimination targets for 2030. Just to make a couple of key points around hepatitis C, it's an 80% reduction in incidence, hepatitis B, it's in fact higher at 95%. So that's how you get the overall 90% for viral hepatitis. But that's a big ask. I'll show you in terms of our modelling how we're going to sort of track towards these elimination goals. There's been some mention of micro-elimination and sort of prioritisation of different sort of groups. In Australia, it's clear, even though we've had an unrestricted DA access program where anyone can come forward for therapy, there's no doubt that there's been some emphasis, at least, in people with more advanced disease for obvious reasons in terms of the morbidity they have and the risk of complications. We've also had emphasis on high-risk populations, so people with HIV, co-infection, and people who inject drugs, and prisoners, obviously, those two populations overlapping considerably. And just to put some numbers to all this, these are our estimates of the populations prior to the DA program. So overall, about 230,000 people with chronic hepatitis C, about 45,000 people who had acquired their infection through contaminated blood products or had migrated to Australia from high prevalence countries. And then the remainder either people that formerly injected or people that are currently injecting. So around about 40,000 people currently injecting. Those overlapping populations in Australia, about 50,000 people are incarcerated per year. Another damning statistic in terms of some things we do badly in Australia. So drug law reform is certainly something we do badly. A lot of work to be done there. 25% of those people who are incarcerated have chronic hepatitis C, so that's where you get the 12,500. 48,000 people in Australia are on opioid substitution therapy, and about half of those will have chronic hepatitis C. That's where you get the 24,000. So those populations, those three, are clearly overlapping. The old system, prior to DA therapy, was multidisciplinary clinics, large sort of tertiary-based sort of care, many people involved. I think the advent of these new therapies and how simple they were, how well tolerated they were, meant that we could completely change this paradigm. So what was developed was a range of different models of care, but much more simplified in terms of the number of people involved, etc., and much more sort of diverse in terms of creating those sort of access points. These are the regimens that we have on what's called the Pharmaceutical Benefit Scheme, the government-funded scheme. So we have almost all the licensed regimens. We have one more to go. So sofosbuvir plus velpatasvir plus voxeloprevir, which is a really important second line or salvage therapy, should be listed on the government-funded program in the next couple of months, and then we'll have it all. So that's, again, one of the key advantages we have in Australia. We have all the regimens available, so we're not like Portugal or we're not like Georgia, where it's been driven by arrangements with Gilead in terms of what regimens they have access to. So the government has negotiated with all the major pharmaceutical companies in terms of getting access to those therapies. And these are the treatment numbers. So in the interferon era, we were a low treatment country. We're only treating about 2,000 or 3,000 people per year. So we're only treating about 1 to 1.5% of people with chronic hepatitis C. We had some access in terms of compassionate access from the pharmaceutical companies from late 2014, so that's where you see the interferon-free DA therapy coming into play. And quite a few people were treated under that scheme through 2015. We also had some generic importation, as been mentioned already. Australia is one of the leaders, in a sense, of the Dallas Buyers Club type programs. So there were many people that were treated through 2015 as we waited for the government-funded program to arrive. And that arrived in March 2016. So the first year, 32,000 people were treated. The numbers inevitably were going to drop. You could never keep the momentum up from that first year. I mean, one clinic where I work at St Vincent's have 3 specialists. In 2016, we treated 700 patients just in the sort of 10 months of the program. 3 specialists, 1.5 nurses. So it was always going to be that there was very large sort of warehouses in terms of people waiting for these new therapies to arrive. So 2017, 21,500 people treated. So around about 60,000 people have been treated so far, a bit over a quarter of the estimated population with hepatitis C. So we are on track. We're one of the countries that was on track in 2016 and have remained on track in 2017. Great to see Switzerland added there, but it'll be important to see what the 2018 figures are. Unfortunately, this website Polaris has been taken down through lack of sort of funding, so hopefully there will be some support for Polaris going forward. But the treatment numbers are declining. So the news is good, but there is some concerning sort of trends, and I think that's why we really need to keep the momentum going. These are the monthly numbers of treatment since March 2016. And in 2017, we're about 1,500 to 2,000 people commenced on therapy per month. So that gave us around about 21,000 people treated. It's come down a little bit further in 2018. I've got some unpublished sort of data through to the end of July, and it's between 1,000 and 1,500. In August, we had Mavorite or glecaprevir prevenosphere listed, so that gave us a bump. So we think we'll get to around about 16,000 people treated this year. Now just keep that number in mind, because I'll show you some modelling data in terms of the numbers we need to treat going forward. So hopefully that number will stabilise, and I'm relatively confident based on a few things that I think the momentum will be sustained. It's interesting but not surprising to see that the age distribution has changed somewhat. So if you look in the early months, March, April, May, a relatively small proportion of people were less than 40. So these in the purple and the blue are people less than 40. So not surprisingly, people in large clinics, generally more advanced disease, older patients. As the treatment has broadened into primary care as well, you're getting a younger distribution in terms of people treated. So we're now treating 30 to 40% of people who are aged under 40. And that's incredibly important in terms of elimination strategies, because it's not people in their 50s generally the population that are transmitting virus. This is the estimated, in the red dot, the estimated total proportion, so total numbers of people by age group with chronic hepatitis C, and these are the proportions treated. So there's a bit of a shift to the right, so higher uptake, so to speak, in those in their 50s, but not too bad in terms of how it maps the estimated total population living with hepatitis C. 2/3 of people infected are male and 1/3 female. This is just the proportion in each of the genders. So it's not 50-50 in terms of gender, it's about 2/3 that are male. So there has been this changing sort of pattern of prescribers in Australia. You can see here in March and April, about 70% were prescribed EA therapy by gastroenterologist or ID specialist. But as we move forward, we're now at a situation where more than half of the prescriptions are by general practitioners and other physicians, and less than half are by specialists. Now, what that's done, I think, is given us a softer landing. So these are the crude numbers of prescriptions. So you can see this is the specialist numbers coming down, and in many countries, I mean, Germany is a prime example, there are other countries where they've really had dramatic declines in the number of people being treated following the first year or so of unrestricted access. So I think it's given us a softer sort of landing, having this sort of broader base in terms of prescribers, but we need to keep adding to that. We need to get more general practitioners on, because a lot of the GPs have treated their little cohort. So they've got 10 or 15 or 20 patients in their clinic, and they've treated those. So we need to get more people involved and spread the education and training to other prescribers as well. The regimens have changed. There's new regimens have come on board. So you can see the pan-genotypic regimen of sofosbuvir velpatasvir is now the most commonly prescribed sort of regimen, and this is data up until March this year. Now, as I said, glecaprevir prevenosphere was listed in August this year, so it'll be very interesting to see how that sort of fits into the market. So we've now got two key pan-genotypic regimens. And the beauty of the situation, as I sort of alluded to in Australia, is that you can make a decision on what regimen you prescribe on the basis of individual patient needs, not thinking at all about cost. So clinicians can completely put cost to the side and think, well, what's the best regimen for the patient in front of me? And that's how it should be. We've estimated that around about 70% of people living with Hep C related cirrhosis, and this would include a small proportion that are undiagnosed, have already received DA therapy. So clearly this is demonstrating there has been some targeting of people with more advanced disease, and many people obviously already in those large clinics waiting for these therapies. That's important in terms of what impact we should be able to get in terms of turning around advanced liver disease complications, and I'll show you some encouraging data shortly that appears to bear that out. It's interesting to look at the proportions of people that are being prescribed across the prescriber groups by the regimens. Now, the point I wanted to make is around 2 regimens. So in Australia, in terms of recommendations, before we had sulfasphosphamide, we had most people being treated with sofosbuvir and declatosphere or sofosbuvir and ledipasvir. For genotype 3, and Australia has a lot of genotype 3, about 35 to 40% of people in Australia have genotype 3. If you had cirrhosis, you received 24 weeks. If you had pre-cirrhosis, 12 weeks. If you had cirrhosis and genotype 1 and were interferon treatment experienced, you also received 24 weeks of sofosbuvir and ledipasvir. So you can see that in general practice, relatively small proportions of the total sort of treatment regimens were for people that had cirrhosis compared to gastroenterologists or infectious disease specialists. So making the point that largely cirrhosis was being treated by specialists. So the specialists were very concerned, some of the specialists, that when we opened it up to general practitioners, that we would have all these people with cirrhosis treated in primary care and there'd be inappropriate sort of management of hepatitis C in primary care. That's not happening. I don't think there's a problem, though, with a patient who's very well compensated cirrhosis receiving their therapy in primary care, particularly if it's difficult for them to get to tertiary care. So if they don't have portal hypertension, they've got a normal platelet count, they don't even need an endoscopy. So as long as they can get an ultrasound to screen for HCC, surely they can receive therapy in primary care. But largely people with very advanced disease, particularly if you've got portal hypertension, and obviously if you've got decompensated cirrhosis, that requires specialist tertiary care-based management. So these are some data from the observational real-world cohort I talked about, REACH-C. We've got over 3,000 patients on that cohort. It's building up to about 6,000 patients. Importantly, like most real-world cohorts, there is a proportion of people currently at about 16% who haven't come back for their SVR12 assessment. So that's an issue in all settings. So this is not a clinical trial sort of setting. And a lot of patients are sort of straggling back in, and we often ring patients and say, you know, you really do need to come back in for your sort of cure assessment, and a lot of patients just haven't got around to doing it. So this data in terms of the per protocol analysis is based on those that have come back for their SVR12. So just sort of keep that in mind. But the cure rates are very encouraging, and as you would expect, and similar to the clinical trial rates. So no impact of HIV status, slightly lower in people with cirrhosis, slightly lower in people that had prior hepatitis C treatment experience, equivalent in people with recent injecting drug use, and equivalent in people on OST. However, the proportion without SVR12 assessment is higher in these two groups. So the more marginalised populations are finding it more difficult to get their cure assessment. So we do need to think of sort of some strategies to try and optimise that sort of going forward. Again, the outcomes are all very good across the genotypes, as you'd expect. Highest in genotype 1, slightly lower, as we see in the clinical trials, in people with genotype 3. And as I said, we have a lot of genotype 3 in Australia. Importantly, they're also very high across the different service types. So whether you were treated in specialist liver clinics, general practice, sexual health service, community health clinics, drug and alcohol services, or prison, you get good cure rates. So look, this is not a terribly complex disease to treat. It's not these are not surprising findings, but I think they're important, particularly for the government, to say, okay, we made this decision to go to a broad prescriber base. We made this decision to develop a range of different sort of models of care. We at least want some data to tell us that it's doing okay. And so I think this is really important. I just wanted to focus a bit more on people who inject drugs, obviously a key population. I've showed you these numbers before, but just to make a couple of other points. So Around about 20 to 25% of people who are currently injecting are incarcerated every year in Australia, a damning statistic. But a situation that Australia, I think, is using at least sort of pragmatically in terms of public health's delivery of Hep C therapy. About 30% of people who are currently injecting are on OST. So the key sort of strategy initially was to develop Hep C treatment services in the OST clinic setting and in the prison setting, but also to develop some innovative community-based sort of treatment programs to reach people who weren't on OST or weren't incarcerated. So there have been a range of different sort of community-based sort of clinic models. So I've been fortunate to work at the Kirkton Road Centre for the last 15 years, which is about 200 metres up from St Vincent's Hospital, which is a tertiary clinic that I established back in the late 90s. Kirkton Road Centre has three key populations: at-risk youth, sex workers and people who inject drugs. So we have there about 400 regular clients who have chronic hepatitis C. We've treated about 65% so far, so a really active program. And I've mentored and built up a team of people at Kirkton Road Centre who now do sort of outreach to a range of other sort of clinics, including sort of homelessness services as well. I still go up there once a month. I'm pretty obsolete, which is nice, but I go up there and see a couple of sort of complex cases per month. The Combi clinic is an innovative sort of model in Queensland with a couple of general practitioners who work in the drug and alcohol sector. Have a sort of fun sort of model of a Combi van that goes around to various places in Brisbane, provides Hep C screening and sort of linkage to care. Those of you who are in Lisbon at the INSU conference might have seen them. They were wearing their Hawaiian shirts each day of the conference, and they're sort of larger than life sort of characters. But it's just an example of a sort of way to sort of make things a bit more sort of flexible and a bit more fun. The other important aspect of care for people who inject drugs is the integration of services into harm reduction, and the Queensland Injectors Health Network have done this really well. And I think that's something that should be done sort of much more broadly, not just in Australia, but obviously huge need globally. And whether hepatitis C can help sort of drive harm reduction coverage is another question that something I was discussing with Unitaid when I met with them on Friday in Geneva. This is just one example of an innovative sort of program. We developed a program called Live a Life several years ago now, where we go into drug and alcohol sector settings, both OST clinics and needle and syringe programs. We take a team of people. It's a research project, so we survey people. We have peer-based support in terms of enrolment and working through questionnaires. Everyone gets a FibroScan, everyone gets a finger stick RNA sort of test. So we have been the group sort of leading the evaluation of the SemiGene Expert sort of platform in the context of this Live a Life program. We evaluated the phlebotomy version first and published that, and then we evaluated the finger stick sort of version. Really innovative, and it really gets around that issue in terms of poor sort of venous access for people who inject drugs. So a finger stick, 100 microliter mini vet into the cartridge, and then 60 minutes later the result. So we're utilising this sort of platform in a range of different sort of research projects. It's just got CE marking, so it is sort of registered now in Europe. Hopefully it'll be registered in Australia early to mid next year, and we'll be able to then use it clinically. But just as an example of the sort of innovative programs we're doing, this is the Tempo study we're just about to start in 3 pilot sites, needle and syringe programs in Sydney, where we're going to enrol people attending the needle exchanges, again with peer support. We're going to do finger stick RNA. We're also going to do rapid HIV and hepatitis B testing. No phlebotomy. So no safety bloods required. Everything done through a finger stick. Everything rapid, and then linkage to care and same-day initiation of DEA therapy with a pan-genotypic regimen, and peer-supported delivery of that Hep C therapy through the needle exchange. So I think these are the sort of innovative programs we need to be thinking about taking forward. There's different sort of models that will be required in different settings. So really exciting sort of project. But we've already done pretty well in Australia. This is an annual Newlands Program survey where we enrol somewhere between 2,000 and 2,500 people inject drugs, attending about 50 Newlands programs around the country. We've been doing this for 20 years, testing for HIV and hepatitis C antibody. We added in several years ago questions around whether you've been treated with hepatitis C, and for the last 3 years we've been testing the samples, which are, again, finger stick but dried blood spot samples. We've been testing them for Hep C RNA. So you can see the increasing proportion of people who say they've been ever treated. So in October 2017, when the survey was done, over 40% said they'd received therapy. And you can see the reduction in Hep C RNA. So the active infection proportion coming down from 45% to 25% in 2 years. Okay, so clearly we're shrinking the reservoir of active infection within this very, very high risk population. Important, obviously, for elimination. And it's interesting, the Hep C RNA positive group will be made up of 3 groups. So those people who've never received treatment, people that have been treated where the treatment has failed them, and people that have been treated and have become reinfected. So I've never been someone who's worried too much about reinfection at all, because I think reinfection is very easy to retreat. All we need to do is to monitor people for reinfection, detect the reinfection cases that occur, and offer retreatment. As part of the Australian program, you can have access to retreatment. So there's no barrier to retreatment. And retreatment's much easier to treat than virological failure retreatments. It's very, very straightforward. Another example of microelimination, this is from a prison outside Cairns in far north Queensland, the Lotus Glen prison, about an 800 inmate prison. A very active Hep C screening and treatment program by Sexual Health Service in Cairns, led by Darren Russell, a sexual health physician and a nurse, going into the prison on a regular basis, and started the program when the DA unrestricted program started. You can see there's about 95% of people coming into the prison were getting screened, so they could look at what the Hep C RNA sort of prevalence. They also did further testing while in prison. So prior to the program, just over 12% of inmates had active infection. By the end of 2017, only 1% of inmates having active infection. In fact, only 9. 4 of those people had just been commenced on therapy, and the other 5 were sort of being worked up. I think they had 1 or 2 inmates only that refused treatment. So look, it can work if you have a very sort of active program. Now, it would be even better in terms of overall elimination if we had needle exchanges in the prison, and I'm certainly an advocate for that, but that is not going to happen, unfortunately, in Australia in the foreseeable future. I wish it was not the case. I wish we did have needle exchanges. We do have access to methadone, buprenorphine, but it'll be interesting to see what sort of treatment prevention benefit we get in the prison setting. Coinfection, I think it's been wonderful what you've achieved here in Switzerland in terms of hepatitis C elimination, HIV setting. We have similar sort of data. This is the CEASE study that enrolled people who are HIV antibody positive and hepatitis C antibody positive. So to get into the study, you had to be antibody positive for both. So up until early 2016, about 80% of those people who are Hep C antibody positive were also positive for Hep C RNA. Now, the 20% of people that were negative would have been people that had previously been treated with interferon-based therapy or had spontaneously cleared the virus. Following 2 years of the program, we're now down from 80% to 9%, okay, of those who are antibody positive for hepatitis C. In Australia as a whole, in the HIV population, about 10 to 12% of people who are Hep C antibody positive. So if you extrapolate these findings to the total HIV population, it means that the active infection rates come down from about 10% to 1 to 2%. Okay, so very sort of similar, I think, in terms of the impact that you've had in Switzerland. And this is some work that we've done with Swiss colleagues, with Louisa and with Andre Rausch, looking at modelling the epidemic of hepatitis C in the HIV population. And there was increasing incidence of hepatitis C, as was also seen in Switzerland, through the 2000s into the 2010s before the DA program started. And the key finding from this modelling is that even if we have increases in risk behaviour, so if we have increases in both sexual and injecting risk behaviour, if we keep the treatment at the current stable rate, which is quite a high rate of treating about 60% of people who are Hep C RNA positive per year, we can accommodate those increases in risk behaviour and we will still eliminate hepatitis C. It's only if the treatment rate falls down to about 20% and we get increases in risk behaviour will we lose control of the hepatitis C epidemic. And because we've treated so many people quickly and reduced that viremic pool, therefore things like the reinfection risk have come right down. So you can get control of epidemics, particularly if you scale up very, very rapidly. But there are sort of some key challenges to keep Australia on track. So we need continued improvement in health systems to provide DA access. Even though we have a high diagnosis rate, a high antibody diagnosis rate, in fact 81 or 82% of people are diagnosed in Australia, there's still a lot of people who haven't had active infection confirmed with Hep C RNA testing. And this is where the role of point of care platforms will be really important, I think. Integration of Hep C screening within homelessness and mental health services. We've done a great job of integrating Hep C into drug and alcohol services in Australia, but there are a lot of people with hepatitis C through homelessness services, and they're the most marginalised population that we have. There's also a lot of people with hepatitis C, I think, in mental health services who may not be accessing hepatitis C care. We're doing pretty well in the prison setting, but we need increased treatment in the prison and community populations, particularly Newlands programs. The non-specialist involvement's encouraging, but as I sort of said before, larger numbers of prescribers are required. And community awareness campaigns are required to enhance diagnosis and linkage to care. And need for ongoing monitoring and evaluation. I'll show you some of the monitoring and evaluation that we're doing. So this is the modelling. So what we did was we imported the treatment numbers that we had for 2015. Obviously, it was compassionate access and generic importation in 2016, 32,500, 2017, 21,000. And then we built some different treatment scenarios. So a very optimistic scenario that said, okay, we'll keep treating at 21,000 people per year. An intermediate scenario that said, okay, we'll fall down, we'll drop by 20% in 2018, and we're almost on target to achieve that 17,000. And then a further 20% in 2019 down to under 14,000, and then that number sort of going forward. And a pessimistic scenario where we drop to just under 13,000 this year and then down to less than 8,000 in 2019 going forward. And to see what impact that would have on our elimination targets. A key assumption in this model is that treatment uptake in high-risk populations is comparable to low-risk populations. Now, our Newlands Program survey data is telling us that maybe treatment uptake's even higher in the high-risk populations at the moment. It certainly is in HIV co-infected population, but we'll need to keep monitoring that. So in terms of what that does, in terms of treatment coverage, the WHO target is 80% of people being treated by 2030. We certainly reach that under both the optimistic and the intermediate scenario. It's only the pessimistic scenario that we fall short. And this is the number of people living with chronic hepatitis C coming down under each scenario, obviously better under the more optimistic and the intermediate scenario. And then let's turn to looking at the numbers of new infections. So WHO targets in the red dotted line, 80% reduction from the 2015 figure. What was surprising to us was that even under the pessimistic scenario, we will get there by 2030. So we can have sort of treatment rates falling quite significantly, hopefully that won't happen, down to less than 8,000 per year and still reach that elimination target. But importantly, as long as we keep treating the high-risk population in terms of equivalent access and equivalent uptake as low-risk populations. What is harder to achieve is the liver-related death target. So to get the 65% reduction, we get there under the optimistic scenario, but we don't quite get there under the intermediate scenario. The reason for that is that it's really tough if your pre-DA therapy curve was on the up. So you can see here, this is the black line's under the interferon treatment scenario. If we didn't have access to DA therapy, we would have doubled the number of people dying from liver-related deaths by 2030. But the target is compared to 2015. It's not compared to where you would have been in 2030. So it makes it pretty tough. So you can turn this epidemic of advanced liver disease deaths around, but to get it down to 65% reduction is really very tough. And it's one of the things I discussed with WHO in Geneva on Friday about this sort of one-size-fits-all global target. In fact, it varies enormously by country. So, for example, if I was in Japan, because the Japanese epidemic is much, much older, in fact, they've peaked in terms of their liver-related death numbers, they wouldn't have to do anything and they'd get 65% reduction because of the shape of their epidemic sort of curve. So it's very, very different depending on that. So they acknowledge that, and obviously they wanted to go for a key sort of global sort of target. This is the changing sort of nature of the population. This is pre-DA access, 227,000, about 10% had cirrhosis, 10% were interferon treatment experienced pre-cirrhosis. And with the numbers that were treated, particularly those two groups, this is end of 2016 and this is end of 2017. And what's important is that we're now left with 95% of the population who are both treatment naive and pre-cirrhosis. So that makes this an infection and a disease that is absolutely able to be treated in primary care and community sort of health setting. It doesn't need to be treated in specialist sort of dinner centres. I'd like to do myself out of a job, sort of part the way there, but I think this is demonstrating that this is a chronic disease that can be integrated into primary care, and it should be. We have lots of things in terms of our evaluation and monitoring sort of strategy. I'm not going to go through all of those. I've showed you some data from some of those monitoring and evaluation sort of systems. But I did want to talk about one key sort of monitoring strategy. So we have a very large data linkage project in New South Wales, the home state for our institute and where I work clinically. We have around about 100,000 people that have been diagnosed and notified in New South Wales. So hepatitis C has been a mandatory notification since 1992 in Australia. So we have very large registries, notifiable disease registries. And we link that to hepatitis B, we link it to HIV, we link it to several administrative sort of data sets, including hospitalisation, cancer registry, death registry. We're also linking it to the PBS, so that's individual pharmaceuticals, including hepatitis C. We're linking it to something called MBS, which is Medicare benefit scheme, which gives you all the item numbers for all the testing, RNA, genotype, ultrasound, etc., etc. We're linking to incarceration, OST registry. So we'll have an incredibly sort of rich sort of data set, and we have some preliminary data from the first linkage to hospitalisation that I wanted to show you. I've got 5 minutes. Very good. Thanks, Maria. That'll be plenty. So this is the data on hospitalisation for liver failure or decompensated cirrhosis. You can see that was sort of trending up until 2015, 2016. Remember, we got that compassionate access for people with cirrhosis in 2015. So the curve has turned around. The dotted line is where it would have continued without the introduction of DA therapy. So very encouraging declines in the number of people being hospitalised for liver failure. HCC is harder to turn around, so at least we've started to plateau the escalating sort of curve. Now the reason why HCC is harder to turn around is that even when people with cirrhosis are cured, there's still some risk of HCC. Okay, so you drop the risk from about 3 to 4% per year to about sort of 1% per year. So because we have lots of people with cirrhosis who have been cured, there's still some of them are progressing through to develop HCC. But the reduction for liver failure is even greater. This curve will turn around. It'll just take an extra sort of 1 or 2 years to get it to start to move down. But importantly, the number of people dying from hepatitis C related liver disease has definitely turned around and would have been frighteningly escalating without sort of the introduction of DA therapy. So if you want evidence of return on investment, this is it. So we're preventing people dying from hepatitis C in large numbers through this very active program. We also want to stop transmission. This is a sort of surrogate for recent transmission. We look at the notifications amongst younger age people, 15 to 24 years. It's too early to see an effect in terms of transmission, at least through this mechanism. The problem is that people that are diagnosed with hepatitis C in these age groups may have been infected, 2, 3, 4, 5, even 6 sort of years ago. So, but it's a sort of monitoring system that we will continue to sort of watch very closely. It is encouraging that even before DA therapy, we had some decline over the last decade. And we shouldn't forget about prevention as prevention. So just because we've got these amazing new therapies, doesn't mean that we can't keep pushing harder in terms of harm reduction sort of coverage, in terms of trying to improve access for people who inject drugs to OST if appropriate, and to needle clean injecting equipment. Just finally, I'd like to thank a lot of sort of people, collaborators, obviously within my home university, University of New South Wales in Sydney, and collaborators nationally and internationally, public and private sector funders for our work at the Kirby Institute. And once again, thank you so much for the invitation to come and present.